everybody can hear me, because I don't know if it's my internet or it's anyway. Good evening again, everyone. Everyone. I'm sorry for today's delay. I just got back a few minutes ago, and into my house clothes yet. So yeah. To our very first class, a lot of signs and symptoms and all that for the past few weeks, and today will be the first class where we are going to put what we've learned for the past few weeks into practice, because to go symptoms all over again, how to detail those symptoms, how to understand what's the underlying problem behind it, what are the possible ways to tackle those problems, and or how about or how our train of thoughts should be directed towards whenever this type of problems come into our hands. So I decided to divide the diseases of the GIT according to the parts of the GI tract, and mainly because I think just following the GI tract, putting in and it in the rectum is just I think it's just the logical way to do it. And of course, the GI tract itself is not an independent like a tube or a hose of water, and that's it. Whatever problem lies in the tube is just in the tube. But of course, there are other systems that work together with the GI tract, and that is your hepatobiliary system as well, right? And in some in some problems, probably outside of these two main systems. So I thought of just going through the GI tract chronologically first, from top to bottom, and then we'll go to the hepatobiliary system right after we're done with rectum. Okay, or maybe I don't know. Maybe I might change my mind, and while we do the small intestine, I just maybe want to, I don't know, hit pause on the track and go to the rectum. Maybe, I don't know. I've not really decided on that yet. But we'll see as the time comes. Okay. So, but basically what we're going to start today, I know for sure that we're going to start as of today, and maybe, I don't know, next 2 weeks. We're going to, maybe just 2 weeks, I don't know, if we can cover a lot of things, and maybe they are not, maybe things are clear, maybe things can be faster, and maybe we can finish in 2 weeks. But if not, it's okay, no rush. But we're start first with esophagus, right? Diseases of the esophagus, like what I sent in the group. The main diseases that I think are important for us to know, and of course, these are not the only diseases that can affect the esophagus. There are so many other diseases as well, but these are the main ones that I think are important and we need to know, at least. Of course, if you are a gastroenterologist, probably you will need to know more and more in details as well on how other systems can affect the esophagus, and all that. Not maybe the respiratory, how the respiratory system can affect the esophagus, and all of that. Just basically intersystemic affection of organs and all that. Of course, I do concede that these things can still exist as well, but these are just the ones that I think are at least important for our for our foundation, at least something to start with, right? We all need to start with something. So in the list that I sent to everybody, I think I wrote achalasia, esophageal gas carcinoma. I don't remember what else I wrote. Esophagitis, biliary waste syndrome. Uh, I don't remember how many diseases I wrote, but basically these are important ones. And some literature or some authors would group them according to different complaints of the patient. Some of can fall under diseases that is under dysphagia, patients with problems with dysphagia. Second is diseases that patients have complaints of pain and also reflux in nature. Um, although although yes, it kind of there's some form of logic behind it of dividing all these diseases into diseases that is that patients can have. Patients can be complaining of dysphagia, a set of diseases complain of dysphagia, and another set of that patient can complain of pain, and another set of diseases that patient can reflux and all that. Uh, then again, I don't think that grouping them exclusively into such groups um, are very wise, because if you really go into different forms of the diseases, you will notice that the signs and symptoms are interlinked. Sometimes the patients can have dysphagia and pain, and sometimes all three: dysphagia, pain, and reflux as well. So I will not group such diseases into all these three groups of diseases: dysphagia, pain, and reflux, because I don't think that it's safe to group them into such groups. Uh, and also, I don't see such classification in Kaplan's USMLE resources. I don't see it in MRCP. I don't see it in any of the UK material, and I don't see it even in RKSMU material. So which gives me enough support that such grouping of the patient is not entirely the wisest thing there is out there. Okay, so with that said, um, like what I said earlier on in the group, what we're going to cover today is first GERD, gastroesophageal reflux disease. Then we'll talk about esophageal carcinoma, esophageal cancer, and Barrett's esophagus. And if we have time, hopefully we can cover esophagitis. I hope that we can all cover all of this, because they are all interlinked. Like I said in the group, these three diseases are very common, especially GERD, especially esophagitis. They are very common, and it's really bread and butter of the GI tract when it comes to GI tract diseases. So, and I also mentioned that it's sort of like once something happens, if it's not being treated well or sufficiently, it's sort of like it has a domino effect. Once this happens, and this happens, you see, you understand later on how GERD can lead to cancer, cancer can lead to GERD can lead to esophagitis, esophagitis can lead to cancer, and all that, and things can get worse and worse and worse to a point that pharmacological treatment or pharmacological intervention no longer works, and we need to resort to surgical intervention, sometimes surgical intervention can work. We don't need to resect anything. If things can get it can get very, very bad, the cancer becomes metastatic and all that, we might need to resect the whole entire stomach, the whole entire esophagus and all that. Things can just escalate very quickly just because treatment is not sufficient, or maybe diagnosis was not made correctly. So yeah, there is a burden when it comes to the diagnosis and treatment of this to start with. Okay, so of course, before diseases, we need to understand the anatomy first. Okay, I hope it's okay to cover anatomy for a bit. Because I think it's important to know the anatomy of the esophagus and see later on how significant understanding the anatomy of esophagus is when it comes to understanding of diseases that we're going to cover. So, of course, the picture that I refer to is, of course, our is the I don't know which version of the textbook. Okay, basically, esophagus, it starts from it starts from C6 to T11 here. C6 to T11, basically C6 to T11, and it consists of three main parts. I'm sure you already know these three main parts. They are the cervical part, the thoracic part, and the abdominal part. Which one is the cervical part? You see that here. Not it. Okay. Here is the cervical part. Here is the thoracic part. Yeah. So what I'm drawing is very bad. And here is the abdominal part. Okay, three main parts, basically these three main parts. The cervical part is approximately 5 centimeter. If you measure 1, 2, 3, 4, 5, what? Correct, 5 centimeter. Part is about 18 centimeter. It's too long. 18 centimeter, and the abdominal part is about 4 centimeter. See approximately 4 centimeter. Okay, so these are the three main parts of the esophagus. We also need to understand there are kind of two so-called sphincter of the esophagus. Now, you might think that the sphincter of the esophagus is just like other sphincter, for example, your anal sphincter, or your duodenal sphincter, and all those things. In your head, you might assume that the sphincters in your esophagus are sort of like that, but in reality, esophageal sphincters are not actual anatomical sphincters. They are just a group of muscles with the assistance of some external organs in those areas that makes them function just like a sphincter, but they are not real sphincter. Okay, so understanding this will help us to know where are the weak parts of the esophagus and all that. But if we really consider them like normal actual sphincters, they're divided into upper and lower sphincters. The upper sphincter prevents reflux into the pharynx, while the lower sphincter logically prevents reflux from the stomach into the esophagus. Those are the two main reasons why they are there. So where are those two sphincters? This is the upper sphincter over here. It's a group of muscles together. You see that that it has cricopharyngeal muscle, part of the inferior pharyngeal constrictor muscle. This is the upper esophageal sphincter, and here is your lower esophageal sphincter. Here over here. Diaphragmatic constriction of inferior here. Okay. Understanding this, we need to also understand that on the esophagus, there are physiological, anatomical narrowing of the esophagus. First is the pharyngeal narrowing of the, or constriction, you may call it, of the esophagus, and that is your pharyngeal. See over here, pharyngeal esophageal constriction. This is your first constriction or first narrowing of the esophagus, which makes it the upper esophageal sphincter. There is next your bronchial. It's not okay, but yeah, what here? Bronchial constriction, the second one. There are actually two here. It should be bronchial and aortic constriction, but they've combined aortobronchial constriction together. And there's here diaphragmatic constriction over here, and your gastric constriction. You can't see it here. Go ahead, and it's not here. This yeah, gastric constriction. So basically your pharyngeal constriction, bronchial constriction, aortic constriction, your diaphragmatic constriction, and your gastric constriction. These are the main constriction or the main anatomical narrowing of the esophagus. Now, the upper esophageal sphincter is your pharyngeal constriction, while your lower esophageal sphincter is your diaphragmatic constriction, or your see it's stated here, diaphragmatic constriction or inferior esophageal sphincter. Here is your upper esophageal sphincter or superior esophageal sphincter. You understand that this muscle over here can, not today, when we learn Zenker's diverticulum, that when this muscle over here becomes weak, or the tone of this muscle it becomes weak, it will develop an outpouching of the pharynx, and that is called the Zenker's diverticulum over here. We'll talk about that a little bit later and not today. But yeah, these are the parts of the esophagus. Besides that, if we really understand the layers of the esophagus, let's see if they have. Oh, basically the anatomy of esophagus is very complicated. You see that there are also not just muscles and organs. There are also vessels. There are also different nerve endings as well that are very important. This is the esophagogastric junction. Esophagogastric junction. This right here is your diaphragmatic constriction, or your lower esophageal constriction, and this is where a lot of problems happen. Problems with your GERD, problems with achalasia and all that. We'll talk about this a little bit later on. We'll understand problems here can lead to a lot of problems. Okay, I don't see any layers. Okay, anyway, next thing that we need to understand are layers of the esophagus. When we cut the esophagus and see layers of the esophagus, just like any other parts of the GI tract, especially when we go into microscopic view of the layers of esophagus, basically they are the four main layers of the esophagus: your mucosa, your submucosa, your muscular layer, and then it ends with your adventitial layer, right? And of course, your mucosal layer consists of few elements as well: your epithelium, your lamina propria, and your muscularis mucosa. So these are the things that constitutes a mucosal layer. And in the mucosal layer, your epithelium in the esophagus is uh, squamous epithelium. It's not sorry, is squamous, yeah, squamous epithelium. Whereas your stomach is columnar, and your intestine is also columnar. So this is the thing that differentiates the epithelium layer of your esophagus and your stomach and your intestine. Why is this important? We'll talk about that a little bit later on. Now, I would not like to talk about. I will try my best not to talk a lot on stomach because that's a whole different organ, and whenever we talk about diseases of esophagus, it's very difficult to not talk about the stomach. So I'll try my best not to dive so much into problems in the stomach. But if I were really to touch a little bit on stomach, I think it's important to understand some anatomical part of the stomach, just a little bit. Okay, I'm not going to go very deep into the anatomy of the stomach. But basically, in the stomach, like what we understand, are different cells in the stomach that excretes different things, right? Both your aggressive factors and your protective factors, if you remember from your propageutics and pet anatomy, pet physiology, everything basically what you've studied since third year onwards. You understand that in the stomach there's gastric factor and there's also a protective factor, and the balance between that is the one that keeps that maintains the condition, the acidic environment of the stomach. And once it gets too acidic, there's some protective mechanism that can help to increase the pH and all that. But the thing is that the mucosal layer of the stomach is able to adapt to changes of pH, whereas the mucosal layer of the esophagus cannot. So if there's any reflux or if there's anything that goes out of the stomach, whether it's GERD, whether it's achalasia, whether it's maybe even vomiting, any normal vomiting, maybe you're just dizzy and all that, then you feel nauseous, then you start vomiting. Any outflow of stomach of gastric content into the esophagus is aggressive to the esophagus, and the mucosal layer of the esophagus cannot withhold or withstand, such aggressive aggressive content. So when that happens, your mucosal layer will be damaged, and it will, if it's not a really serious problem, of course it will regenerate itself, and the problem will not be there anymore. So yeah, with that said, we'll talk about how this can lead to some problems later on. Okay, so this is the anatomy, the important parts of the anatomy that I think are quite important to remember. Okay, so if we don't have any questions about anatomy of the esophagus, let's start talking about the diseases. All right, I've decided to do today's class a little bit differently. I would like to show everybody vignettes, case study, instead of telling everybody this is what you need to know, this is what you need to know, what's the classification and all that. Okay. I sort of came up with three vignettes, and if we have time, I'll just create a problem and see if we can diagnose it. Hopefully my brain can create another one. Anyway, Let's try the first one, okay? A 32-year-old man comes to the emergency department for substernal pain for 2 hours duration. He says that he sometimes gets this pain while lying in bed at night. He is otherwise free of symptoms, except for a non-productive cough that he has had for the past month or so. Physical examination is unremarkable. ECG is normal. He is given sublingual nitroglycerin and notes that his chest discomfort is worsened. Okay, before we go into, okay, if I get rid of today's topic, I get rid of the fact, we all get rid of the fact that we're not talking about GIT problem. Okay, we're not talking, let's say we're not talking about GIT problem. This patient just walks in. Nobody tells you that we're studying GIT today. So all the patients today will be GI problems and not other systemic problem. Not a heart problem, not a pulmonary system problem. Okay, so this patient walks in for you. With all this description over here, to an emergency department somewhere, it's not even some clinic setting and all that. It's in an emergency department. It means there's some form of urgency in here, right? Okay, so what are your differential diagnoses first? Anybody would like to chip in? What is your differential diagnosis here?
MI.
MI, okay, good. Anybody else? Lying in bed at night. What can that tell you? At night. Chest pain at night. Angina-like pain at night. Anybody? No? What type of angina comes at night? Come on, people. We've talked about this. We did CVS already. I believe in you. Come on. What type of angina is at night? People, or am I not audible? People. Okay, I can hear myself. It means that I'm
Plasmato's angina.
audible. Okay, good. Princemetal angina or your vasospastic angina. Okay. What are your other differential?
GERD.
Given sub, okay. What? GERD? Okay,
The
GERD.
gastroesophageal.
Okay, any other differential? How about unstable angina? Given sublingual nitroglycerin, chest discomfort does not go away. Possible?
Yeah, possible.
Okay, possible. Esophagitis, possible?
Yes.
Okay. What else? Do you guys remember how to create differential diagnosis? Do you remember the acronym that I gave everybody? What is the acronym that I gave everybody? Those who were there when I explained what's the formula to create differential diagnosis? We won't go through all of them to create differential diagnosis. We don't have that much time, but I would just want to hear what's the acronym that I gave everybody, just to make sure that, you know, there's something that's retained. Anybody? Polycarp. I remember the class that when I explained how to create differential diagnosis, you yourself, you told me that, it was a very interesting class, and that it was very helpful to think about, it's a good way to know how to come up with differential diagnosis. I remember you telling me that.
Yes, I remember too.
Oh dear. Okay, so what's the acronym? Do you remember?
I'm trying to remember.
Anybody else remember?
Is it the vitamin
Maladies. Yes, vitamin what?
vitamin A, D, E, K?
Okay, vitamin A, D, E, K. I also explained to everybody how, you know, that there's a version of that. There's a very long version of that, but I explained to everybody the long version of that simply because, well, it covers a lot of things, more things than the shorter version and all that. Of course, it can get a little bit what's the word? Exaggerated, but then again, it covers a lot of things. So if you don't remember how to formulate an easy way to formulate differential diagnosis, you can I don't know, find online or something this acronym right here, your vitamins A, D, E, K. Some people might add some more alphabets in there, but it's available online. It's not something that I came up with. It's out there. It's not a big secret. Okay. All right. So with that said, let's go back to this case right here. 32-year-old man with the differential diagnosis that we had earlier on. We've talked about MI. We've talked about angina, different types of angina, stable angina, unstable angina, prince-metal angina. Basically, your coronary artery disease, your ACS, or maybe not just ACS, maybe maybe CCS too, but your coronary artery diseases. We talked about esophagitis, we talked about GERD, we talked about maybe if you would like, we can talk about problems with the spine as well. Like okay, anyway, let's not go into that. We'll talk about a lot of things later on. But anyway, understanding this, you see, the problem here, of course, from the topic itself, we know that this is a GI problem. If it's not a GI topic, then it's a bit difficult for us to, maybe difficult, or maybe confusing, because the symptoms of CVS, a lot of the symptoms are reflective of CVS problem, and also a little bit it reflects of GIT problem, right? But you see over here, the age of the patient is 32 years old, right? Substernal pain, 32 years old, not that old. Not even the typical age group for any CVS problems, right? So, but then again, of course, we still need to rule it out. Just because the patient is 32 years old does not mean that MI cannot happen in a 32-year-old patient, or stable or angina pectoris to happen in 32-year-old men. Of course, it can happen. So that is why, of course, routine you have to give. You have to check ECG. See over there it says ECG is normal. So MI is out, right? MI is out, or any arrhythmias or whatnot. ECG is normal. Okay, so that is out. That is out. So you see, the next thing that we need to, of course, we if you want, we can check for your cardiac enzymes as well, just to confirm, because sometimes ECG cannot reveal MI. So next thing, maybe you can do your cardiac enzymes, your troponins, your myoglobins, and all of that of that can be done as well. Then you see here the characteristic of the pain. Remember how to characterize pain? Remember what is the acronym to characterize pain? Everybody come and enlighten me.
Socrates.
Maladies. Okay, good. Socrates. Okay, so you see here the pain is substernal. Duration 2 hours. Of course, the description of the pain is not full. So according to Socrates, the acronym we need more than that. But you see, by lying in bed and at night, what might send us thinking that this is princemetal angina is simply just at night, right here. So that's something that can help, that might give us an idea that this might be princemetal angina. But you see here, the problem is here while lying in bed. While lying in bed, princemetal angina can happen even when you're sitting down. So why is the problem, or why does it arise while the patient is lying in bed? So that is something that we need to start thinking now. Is this a CVS problem, or is this a GIT problem? So this lying in bed thing is now pointing us towards GI problem rather than CVS problem, right? Next, he is otherwise, except for non-productive cough that he has had for the past month or so. Non-productive cough. What does that show us? Is it problem with the respiratory system now? Maybe, maybe not. Maybe it's bronchitis. What if it's bronchitis? Right? So another differential, right? Non-productive cough. What type of bronchitis are we talking about? Bronchitis, chronic bronchitis, 32-year-old. There's no here it's not written if the patient is smoking, so it can be some form of maybe COPD, maybe, or maybe chronic bronchitis, or maybe acute, just acute onset of bronchitis, maybe. And then if he continues to smoke, if this 32-year-old man continues to smoke, probably can lead to COPD too. All right. So here another differential to think about. A physical examination is unremarkable. ECG is normal. He's given sublingual nitroglycerin. So see, giving nitroglycerin, simply that means that the medical personnel, the EMT, yeah, emergency medical team, is the team is thinking of angina, right? Regardless, stable angina or unstable angina, they're thinking of angina. So that is why they give nitroglycerin, thinking that it will help. But lo and behold, it did not help. And what's worse, that the chest discomfort becomes worse and not even getting better. So what is the problem here? What is the problem here? Is it CVS? Is it a GIT problem? Right? So this patient has GERD. Okay, this vignette is a vignette that reflects GERD. Why did I add in what the other symptoms that can confuse us? It's because in reality, this is it, that some diseases can mask the actual problem that this patient has. What is the what symptom is the one that that stands out from other symptoms, other complaints as well, is that one, the lying in bed over there, and chest discomfort become worse because nitroglycerin is supposed to help in angina, right? Unless this is very extremely severe form of stable angina, or maybe this is unstable angina, or maybe MI even, right? But 32-year-old man, what's the likelihood for it to be MI, right? Very low. So that is why now with the age, with the position of the patient, you're not thinking of GERD, right? So what is GERD? Gastroesophageal reflux disease. It is simply just the reflux, basically out the backflow of the content of the GI tract, content of the stomach into your esophagus. Basically that's it. Patient can complain of all these symptoms right here that I've listed here. And besides that, patient of course can have vomiting, can have sometimes can have, what do you call that, this mild odor of the mouth, halitosis. Yeah, halitosis. That means the a very weird bad odor of the mouth, and that is quite characteristic for GERD. And if it's long standing, sometimes, you know, with a lot of vomiting and all that, the whatever it is that's coming out from the GI tract, it will go into your esophagus and it will go into your mouth, right? So, and you see that the teeth of the patient might be eroded. Patient probably has the patient might if it's not being treated, might have caries, maybe the enamels of the teeth might be thinner and thinner, sometimes if not even caries, if it starts getting infected, maybe periodontitis as well, the inflammation of the crown of the teeth as well. So with all of this, we have kind of ruled, we need to first rule out CVS problem, right? Because that is in reality, that is more urgent rather than a GI problem, right? If you see the patient is not really showing severe symptoms of GI tract symptoms, so that is why the first thing the medical team will have to think is CVS problem. And once that's ruled out, once that is ruled out, then we can move on to other problems, and that is your GIT problem, right? Okay, so now the problem about GERD is the lower esophageal sphincter, that diaphragmatic constriction that we've talked about earlier on. And a lot of things can cause the tone of that sphincter to be less and less what's the word? The tone becomes less and less strong. I don't even know the word for it. Less and less effective at preventing the reflux of the gastric content into the esophagus. Some of them include smoking. Nicotine cannot help. Nicotine can cause the sphincter to not close properly. Alcohol can do that. Caffeine can do that. Chocolate can do that. And we know that this is a result of the cholinergic system, right? So it means that if the patient is taking mucolytics, it can affect the tone of the constriction as well. Calcium channel blockers can do that too. Calcium channel blockers are supposed to dilate, right? Because if you really want to go into the physiology or pharmacology of this drug, is that of course when we talk about dihydropyridine, calcium channel blockers, and even both non-dihydropyridine and dihydropyridine calcium channel blockers, which are more cardio specific. Although we would like to dilate vessels and all that, well, calcium channel blockers aren't really dilative anyway, but it can cause the sphincter to kind of not relax properly too. Nitrates as well. Nitrates are supposed to be vasodilative, right? But in the muscles and all that, it's the opposite. That it instead of helping to kind of constrict the muscles, it's not helpful at closing the sphincter is not effective at closing that hole over there. So that is why that patient over there just now, that 32-year-old patient, when given nitroglycerin, that is why it got worse, because nitrate worsens GERD. Okay, so the most helpful way to diagnose this patient is well, if you like to if you are in a very cost friendly, let's put it that way, cost friendly hospital, clinical picture is kind of sufficient enough to put your diagnosis, but of course we need to rule out other problems as well. For example, your gastritis or peptic ulcer, of course you need to rule that out, and by ruling that out you need to rule out Helicobacter pylori. You have to rule out maybe bleed and all that. Of course those things we need to rule out, but if it's not being, if you don't see that it's actually gastritis or any peptic ulcer, then there's a chance that it's GERD, right? So besides that, maybe you would think that barium contrast can help to diagnose the patient, but in reality, barium swallow or esophagography or barium contrast is not really that helpful at diagnosing gastroesophageal reflux, your GERD. Achalasia, yes, achalasia. The problem is still also in the lower esophageal sphincter, but the problem is not the problem is not relaxation of the sphincter. It's the absence of such relaxation, and that the sphincter is not opening at all. So that is why barium swallow is a good way to diagnose achalasia, because you can see that the esophagus is dilated and the lower esophageal sphincter is constricted. They call it the bird's beak picture of achalasia, but we're not talking about achalasia today. But now that the sphincter is not properly closing, and probably it's open a little bit, and it causes the content of the stomach to spill out into the esophagus. That is why barium swallow is not very effective at diagnosing that. You might also think that endoscopy might be helpful too. Of course, it can be helpful, but it's not helpful at confirming your GERD. It can help you to confirm other diseases, for example, your peptic ulcer, and if you want to take biopsy, of course, your endoscopy, your gastroesophageal scopy can be helpful. But to confirm GERD, these two things are not really that helpful. Okay, so the gold standard for GERD is they call it 24 hours pH monitoring. What they do is that they put a tube into the esophagus, as close as they can to the esophageal gastric junction, and it's going to be there for 24 hours. And is it optimum? Is it very, very nice for patients to do that? No, that is why it's not very routine to do that to confirm GERD. So most clinicians will just put a diagnosis of GERD based on clinical picture and all that. And I'll tell you later on how clinicians reach to the conclusion of GERD without the 24 hours pH monitoring. So okay, let's talk about the 24 hours pH monitoring first. So what they do is they put a pH meter in, of course, like a tube, as close as they can to the junction, and that it measures the pH of that area, and the average pH, the dynamic of the pH, for 24 hours. And the drop in pH of the esophagus is reflective of a reflux problem, right? So that's how the gold standard of identifying or confirming GERD, unlike your barium swallow and your endoscope. So if you're not, if your the hospital that you're working is cost friendly, then your first step is to prescribe proton pump inhibitors, because acid reflux and all that, you want to reduce um the acid secretion and all that, because you might think that this is gastritis and all that. So you give, as usual, your proton pump inhibitors. You might think that this is gastritis, right? But of course, if there's no indication that this is a Helicobacter pylori problem, you don't give your antibiotics like metronidazole or erythromycin, or to follow your triple or quadruple therapy for your peptic ulcer. Just give proton pump inhibitors first. So you give your proton pump inhibitors for about like maybe 4 weeks or so, and see if the condition improves. And of course you need to make sure that the patient is taking the drug correctly as well. By correctly means that the patient will have to take the proton pump inhibitors around 30 to 40 minutes before eating in an empty stomach. Which proton pump inhibitors, that's entirely up to you, because sometimes the problem of GERD may not be that severe, so you can just simply give omeprazole, and that's fine, unless you think that, well, a stronger, more effective a newer proton pump inhibitors is indicated, you probably can give esomeprazole. That's the best one and then lansoprazole if you like. But just a simple classic omeprazole is fine too. But if after 4 weeks there's no improvement, then you do your endoscopy. If you do your endoscopy and you see that your esophagus is inflamed, esophagitis, signs of esophagitis, then that confirms GERD. Plus, you have to do your 24 hours pH monitoring as usual, if you would like. But most of the time, the 24 hours pH monitoring is not needed if you already see signs of esophagitis. But if your endoscopy, your esophageal gastroduodenoscopy, or maybe you don't even go as far as duodenum, is normal, then of course you need to do your 24 hours pH monitoring. And of course, when you do your 24-hour space monitoring, you have to stop your proton pump inhibitors, and this will in turn definitely confirm your GERD. If you confirm that this is GERD, the best treatment for this is you can give proton pump inhibitors, and also of course lifestyle modification and all that, like maybe stop smoking, stop taking too much coffee or chocolate and all that. And maybe you can ask the patient to not lie down as much, like the patient, like what we had early on. The patient complains of the pain while lying down, right? And maybe you can tell the patient to elevate the head a little bit while sleeping and all that. So on top of that, maybe it can help. But the problem is not with the gastric acid secretion. The problem here is the abnormal constriction of the lower esophageal sphincter, right? So that is why your proton pump inhibitors can only help so much. And most of the time you need surgical manipulation for this. And this surgical intervention is called Nissen's fundoplication. Maybe those in maybe 6th, or maybe not 6th, probably in 4th year, probably. You've heard of Nissen's fundoplication, but you probably learn more on Nissen's fundoplication in 6th, maybe. Basically, it just takes the fundus of your stomach and puts it around the esophagus, sort of to mimic the sphincter, or helps to kind of constrict the sphincter, constrict the area a bit. And when the sphincters try to contract, or to contract, then it actually contracts fully, right? That's the purpose of Nissen's fundoplication. So yeah, that's the way to solve the problem. Maybe if you think that if the symptoms are not that severe, you might want to prescribe your H2 blockers, like your cimetidine, ranitidine, and all those things. But if you really want to compare your H2 blockers, cimetidine, ranitidine, they are not as effective as proton pump inhibitors. So it's still best to prescribe your proton pump inhibitors, right? Okay, so the problem with yeah.
I have a question. Is it okay to combine acid together with proton pump inhibitors?
Combine what with what?
Antacids with proton pump inhibitors.
Antacids.
Yeah.
Yes,
Okay?
it's possible. Yes. In fact, we'll not go into great detail about this, but if you really if you study the treatment for peptic ulcer, you see that quadruple therapy, although it says quadruple therapy, can add in other things like antacids, and or other things that can help to neutralize the acidity. So yeah, it's possible to prescribe antacids together with your proton pump inhibitors. But of course, when it comes to antacid, you need to be concerned. You need to think about the side effects too. Proton pump inhibitors, they have their side effects as well. The headaches is always the problem. And like what we talked about earlier on, if the patient has diarrhea, then has diarrhea or constipation, you need to know which antacid to give, whether it's aluminum hydroxide or magnesium hydroxide, right? Okay. Right. So the problem with GERD is that if it's just being treated conservatively without any surgical problem, it means that the problem can prolong for a very long time, and patient can be on proton pump inhibitors for quite a long time. So the problem of reflux can come anytime, and it can go on and on and on and on. The content of the gastric of the stomach can go into the esophagus and start, irritating the mucosal layer again. The mucosa regenerates, it regenerates sometimes. If it's too much, then it might go deeper, and this can, instead of can form scars. So the esophagus starts to, becomes, the lumen of the esophagus becomes smaller and smaller, and it causes something called esophageal stenosis. So that's also one concern of GERD. Next concern of GERD is that the constant aggressive factor of the stomach content, like I said earlier on, and the esophagus cannot withstand such aggressive factor. So what the body would want to do is to adapt to that, right? And because the body wants to adapt to that, the epithelium of the esophagus will now start to change. It's supposed to be squamous epithelium. Now it's slowly changing into columnar epithelium, right? And this is called metaplasia, the replacement of the lining of the squamous epithelium with not squamous, columnar epithelium. And this is what we call Barrett's esophagus. It's when the lining changes, there's metaplasia. Now, what is the difference? Can somebody tell me the difference between metaplasia and dysplasia? Path anatomy. Metaplasia and dysplasia. There are two different terms that we need to understand. Anybody? No? Okay, for the sake of time. Metaplasia is the replacement of cells with another cell, while dysplasia is not any replacement. But the problem is the cell itself is now different in comparison with other cells around it. So in other words, you might think that they are almost kind of the same, but well, it's not entirely the same, because when it comes to dysplasia, the cell itself is different. It's not being replaced. It's just suddenly a new cell is formed, and the tissue, and starts to duplicate, and it in turn becomes cancerous. But to say that there are two different entities is also not entirely correct, because metaplasia, as it becomes more and more severe, it starts to undergo dysplasia, and after dysplasia, it starts becoming tumor tissue. That is why in Barrett's esophagus, in the long run, it can develop into esophageal carcinoma. So if you have long-standing GERD, and this, if you have long-standing GERD, your probability of it becoming turning into Barrett's esophagus is approximately 0.5 to 0.8% per year, your risk. If you don't treat it well, or if you don't, solve the problem and all that, that's the risk. Even if you treat with proton pump inhibitors, there's still risk to do it, to solve the problem is surgically. But you might think that the numbers are not, not that big, 0.5%, 0.8%, what's that, right? But then that's per year. So if this problem persists, let's say for 30 years, your chances are cumulatively is no longer 0.5 to 0.8. Imagine every year. Next year, it's 0, it's 1. Then after that, it now increases again in fifth time. And once it forms Barrett's esophagus, once there's metaplasia, the person's chance forming adenocarcinoma is 500 to 100-fold. Do you see how big the difference is? GERD into esophagus into Barrett esophagus might be small, but Barrett's esophagus is a question.
Norman, you were breaking. Can you repeat the last sentence?
Which last sentence?
From the cumulative percentage risk.
So accumulate once GERD turning into Barrett's esophagus cumulative might seem like it will only take a very long time for it to, right? But your chances increase. What is suddenly one day it forms metaplasia, and unfortunately that very moment it falls under, let's say, even if that day is like maybe cumulatively it's only 2%. You're now 2%. You have a 2% chance of forming metaplasia. What if unfortunately on that particular day is the day of 2%, right? But once metaplasia starts, means that there is Barrett's esophagus already. The chance of it turning into adenocarcinoma is 50 to 100-fold. 50 to 100-fold. So that is the biggest concern over there. It's not the transformation of GERD into Barrett's esophagus, but when it starts to form Barrett's esophagus, it's almost very certain that it will form adenocarcinoma, right? Okay. About esophageal cancer. I will not go into great detail of esophageal cancer because this is not an oncology talk. If you talk about oncology, there are a lot of different forms of esophageal tumors or cancer, not just the main ones. But the two main ones that I would like to talk about is your squamous cell carcinoma and your the two main ones. If you can't remember the rest, these are the two main ones. Okay, your squamous cell and your adenocarcinoma. Why is it squamous? Because like what we understood earlier on, the lining of the epithelium is squamous cell, right? So it means that the lining of the esophagus is intact. Why adenocarcinoma? Adeno means that it's gland, right? Glandular tissue. And glandular tissue, the origin of glandular tissue is not squamous epithelium, it's columnar. So that is why the adenocarcinoma refers to that transformation, that metaplastic transformation transformation Barrett's esophagus into adenocarcinoma. Okay, and that, by the way, another term, a very, it's not really, the older kind of way to, they kind of describe the metaplastic changes between GERD and Barrett's esophagus. They call it intestinalization of the esophagus, because the lining of the lining is now looking, the lining of the esophagus is now looking as if it's the intestines now, or the stomach. Okay. Adenocarcinoma versus squamous carcinoma of the esophagus. Now, how do you differentiate that? The squamous cell carcinoma is typically almost always the upper two-third of the esophagus, while adenocarcinoma is almost always the lower third of the esophagus. I hope everybody understands why. Because your reflux will, start going out, going up, going out, going out. It's a once it's always coming out, coming out, coming out. So it starts, undergoing changes from bottom up instead of upper, instead of up down, right? Just like, you go to the seashore, see the water, it starts coming from the sea up like that, right? So yeah, so those are the two main groups of carcinoma that I would like to talk about. Alcohol intake, alcohol abuse, smoking, they are predisposed to squamous cell carcinoma in opposed to adenocarcinoma, but patients with long-standing GERD is predisposed to adenocarcinoma. So treatment of that, I don't know if normal internal medicine doctor would do that, but most likely is the oncologist going to treat. You can treat with the therapy, radiotherapy, and all that. Probably resection of the esophagus and all that, but typically go for resection because it's not very helpful, and most of the time it's palliative. Even the treatment is usually palliative, because the chances of survival, when it comes to cancer, they and the prognosis for esophageal carcinoma is at most 20%. At most 20%. So because the numbers are not really that encouraging, most of the time it's just mostly palliative care. Okay. Resection, it's very radical. That is why people don't really want it, and a number of patients die. 1 in 4 patients die during the operation. So very encouraging, and so that is why they don't really like to do surgical treatment and all that. So they'll just do palliative care, supportive care, basically. These symptoms and all that, they just treat the problem and all that. Dysphagia and if vomiting, all those things, you give your antiemetics and cure the symptomatic problems. That is why I talked about the symptoms early on, because sometimes there's no other way but to treat just the symptoms and not the actual. If not talked about esophagitis, let's see if okay, let's not talk today, because I think to cover for esophagitis but you just a task, a vignette, and you see how is it? What? Okay, let's see the second one. 62-year-old man comes in for evaluation, progress solid and recently semi-solid for 4 months. Okay. He has noticed 20, I did not, this one over here, I did not create it myself. I got this from USMLE. So that is why this 20 is, we are supposed to use kilograms, right? I don't even know how to convert pound to kilograms. So anyway, just bear with it. He has noticed 20 pound weight loss. His past medical history is significant for reflux esophagitis for 15 years and 40 pack year smoking history. On physical examination, there's 1.5 centimeter left supraclavicular lymph node is found. The remainder of the physical examination is unremarkable. All right, there's plenty of things to talk about here. First and foremost, difficulty in swallowing solid and then semi-solid food for 4 months. Dysphagia, right? I can point, if you want, you can read up on staging of dysphagia. You can find it around. I don't know if it's available everywhere, but if you can't find classification of dysphagia, let me know. I can send it to you. The classification of dysphagia. They are classified according to the type of food that the patient can swallow. So that is why here progressive difficulty swallowing solid and recently semi-solid. So the more liquid the patient permits to swallow, the worse the dysphagia is. Semi-solid is approximately stage 3 dysphagia already. Then he noticed weight loss. This is an alarm sign. Remember, when we talk about alarm sign, this is an alarm sign. Weight loss already. Past medical history is significant for reflux esophagitis for 15 years. Reflux esophagitis for 15 years. GERD, right? For 15 years. And 40 pack year smoking history. 40 pack year smoking history. Physical examination, 1.5 centimeter radicular lymph node is found. Okay, you see some form of attachment of lymph nodes here. Is it a lymph nodes though? We don't know. Maybe it's metastasis or something. It's only physical examination. If it's metastasis, this is what we talked about earlier on, Virchow's node, right? On supraclavicular, that this might be examination unremarkable. So you see here, first problem, reflux esophagitis. So you might adenocarcinoma of, but you see 40 pack year smoking history. So it's possible as well that this might be squamous cell carcinoma of the esophagus. 2, cancer at the same time, possible cancer, possible, right? And you see that there's 1.5 centimeter of lymphadenopathy. So your differentials over here, there are a few different types of esophageal carcinoma, squamous cell or adenocarcinoma, number 1. Then you see that supraclavicular lymph node, probably a metastasis, possible metastasis of other cancer, can be lung cancer or different cancers, any metastasis into the supraclavicular lymph node possible. So we need to, of course, send this patient to oncology as well to check for oncomarkers and all that, and to do biopsy and all that. So that's next. What else? What else did I want to say this now? Right. And to check the reflux esophagitis, confirm that it's reflux esophagitis as well. We'll talk. We unfortunately don't have time to talk about reflux esophagitis, but GERD itself, right? Another problem as well. Another diagnosis, you can put GERD as well. So yeah, it's a lot to talk about here, to investigate. It's a lot to investigate here. You want to do your endoscopy and all those things. There's a lot of things to do here. What is the prognosis for this patient? Of course, the prognosis is already not good. You see that the patient is already 62 years old, already smoking history for 40 pack year, 15 years of esophagitis as well, and you see this lymphadenopathy as well. Of course, in a lot of things can cause lymphadenopathy, be it your tuberculosis, be it your, be a lot of things, infection and all that, they can cause lymphadenopathy. So that's some other differentials that you can rule out. Okay, so that's it for today. Do you guys have any questions? Or we've already exceeded by 4 minutes. Any questions?
No question.
No questions. If no questions, all right. So thank you for today. Next week we'll continue with esophagitis and maybe 1 or 2 more problems in esophagus. All right. Have a nice evening. Starting class again tomorrow.
Thank you.
Have fun.
Thank you.
Thank you very much.
Bye-bye.
Bye-bye.
Bye.
Possible.